This is the second generation doctor of Purnia who is taking over from us, and his son of our great friend Dr. SPC MD. I will not like to call him junior. So Dr. Sunil Hars, the question to you is, how different is the management of diabetic gastroparesis compared to non-diabetic gastroparesis? How different it is to manage diabetic gastroparesis compared to non-diabetic gastroparesis?
Good evening to everyone, and thanks for the question. First of all, I would like to thank the Kaidila Pharma to organizing such a wonderful event and giving us this opportunity to be in front of you and to have some good interaction. And thanks for Dr. Devi Ram sir for such kind words. So first of all, I would like to classify gastroparesis. Gastroparesis, like in the question, it is two types, diabetic and non-diabetic, whereas the gastroparesis is of multiple sorts. There are multiple etiologies, like diabetes is one of the most common etiology among them. So once we are dealing with diabetic gastroparesis, so first of all, it goes with good glycemic control. Everything in diabetes goes with good glycemic control. So diabetic gastroparesis will have to be having a very good glycemic control, and all the other gastroparesis along with diabetic gastroparesis has to have a very good healthy lifestyle, has to have a better eating habits. In the way like gastroparesis has delayed gastric emptying. So in all the way in which it increases the gastric emptying, those things should be taken like vegetable and fruits, good amount of water, and anything containing high amount of oil and fried products will cause delay in them. So just sticking to the question, difference between diabetic and non-diabetic is to have a very good glycemic control, and all rest of all the medications as well as treatment goes almost parallel. Except that if there is some drug-induced gastroparesis, sometimes when there is even in diabetes, metformin causes delayed gastric emptying. So all those type of things like drug-induced or psychiatric drugs causing delayed gastric emptying. Else, all of them goes parallel to each other. If some questions are there, then like case to case, it differs. I try to answer if there is some. Thank you, sir.
What you are trying to say that gastroparesis of diabetes delays the gastric emptying.
Correct.
And reduces the gastrointestinal motility.
Yes.
And proper control of diabetes or hyperglycemia itself will help in the treatment of gastroparesis.
Yes, yes.
What is the role of prokinetics in the treatment of gastroparesis?
Prokinetics, the best prokinetics which can be used for increasing the gastric emptying is metoclopramide. And the most commonly drug which we are using nowadays, everything, we even have fixed dose combination which comes with domperidone. So we continuously use in our clinical practices domperidone, which has around 30 mg, which we are using. So we can even increase up to 20 mg thrice a day, that is 60 mg is the maximum dose. If it doesn't work, then we can be thinking about other drugs like erythromycin. Erythromycin can be given as 250 mg, it can be given as maximum up to 6 hourly. Then definitely the gastroparesis has similarly like electrical circuit. Interstitial cells of Kazal is the main cells which causes the motility of the intestine. There are new drugs which are there which increases the excitatory factors of the interstitial cells of Kazal, like if it is mainly towards the constipation side, then we can be using like prucalopride, which helps in increasing the motility, and it helps the smooth muscle construction, as well as it helps the chloride channel, which increases the bulk. Another one thing is we can use levosulfide. Levosulfide even increases the gastric emptying time, but it even has some of its side effects. Basically, sir, it becomes very difficult because over here, first of all, I would like to say that gastric emptying should be calculated, should be documented, like what is the time amount, whether it is there are three criteria in it: mild, moderate, severe. So all those things like we can be using like egg scrambles and all those things which are like quite theoretical, which we cannot practice over here. But yes, with fixed dose combination, domperidone, erythromycin, ibosapride, and if nothing works, then yes, can be used. It works, mainly it doesn't work. But for fungal contraction, like for functional dyspepsia, there has been few papers which are there in ecoshiamide. Ecoshiamide has shown that it gives very good fungal contraction. So people having functional dyspepsia or something like postprandial fullness, having delayed cardiac emptying will be benefited with ecoshiamide. So that's what I was mentioning, that it is very difficult for us to give a thumb rule that this drug will be very effective in all the conditions. And like diabetic gastroparesis might be having very slow peristaltic movement, which can cause like SIBO, small intestinal bacterial overgrowth, and most of these patients are obese. And then,
do you think ecoshiamide will replace all these drugs in future?
Sir, ecoshiamide is quite a very new drug, and still the worst part of ecoshiamide is they say the half-life is obtained after 2 weeks of treatment. So once the half-life is obtained after 2 weeks of treatment, and before ecoshiamide, one tablet used to be 19 rupees per tablet. So giving it twice a day is 57 rupees. 57 rupees for 14 days, no symptoms relief in a patient. So you can imagine in your clinic at Purnia, if someone is coming to you, like for someone like me who is very new, might be 2 weeks, no symptom relief, he might not return to me.
Good. Thank you very much, Dr. Sanil. Now I move on to the Dr. K.M. Kumar. And the question to you is, cardiac complications observed due to obesity?
Thank you, sir, and thank you, Kerala, for organizing such a wonderful event. Obesity is, as we all know, obesity is associated with so many comorbidities like hypertension, dyslipidemia, metabolic syndrome, and diabetes. So indirectly it causes coronary artery disease that we all know better. The new concept now is obesity is directly causing the cardiomyopathy, that is left ventricular diastolic. So many new entities nowadays like arrhythmogenic right ventricular cardiomyopathy. Earlier it was known to be due to fat deposition, but nowadays it has been found that it is due to myocyte degeneration that later on replaced by fat. The second entity is right ventricular fat deposition failure. Obesity is in the second cause of cardiac morbidity is obesity cause sleep apnea. Obesity is associated with sleep apnea syndrome that cause pulmonary hypertension, and it leads to right ventricular failure and CHF. So these are all the cardiac complications.
What you are trying to say that obesity is in itself a great disease and can cause lot of diseases itself.
Lot of diseases.
It is part of metabolic syndrome, which includes insulin resistance, hypertension,
exactly,
and increased incidence of ischemic heart disease.
Ischemic heart disease.
Because this metabolic syndrome also constitutes hyperlipidemia is also a part of the metabolic syndrome. So it's a very great event.
Yeah, actually it causes two types of syndrome. That one is cardiovascular, cerebrovascular, that is associated with artery, coronary artery disease. The second is pumping activity of heart. So there are two types of disease obesity cause. Indirectly it causes coronary artery disease leading to ischemic cardiomyopathy. The second is obesity. Obesity itself caused diastolic heart failure and obesity associated cardiomyopathy.
Right. Can we ask you, what are the complications of COPD?
COPD, the cardiac complication is mainly again associated with pulmonary hypertension and cor pulmonale. That is pulmonary cause that leads to cardiac complication is called pulmonary. And again, it leads to right heart failure and congestive heart failure.
COPD will lead to pulmonary hypertension. This is often underdiagnosed, I must say you, because I do a lot of echocardiography, and pulmonary hypertension is probably far more common than we realize or is written in the textbook.
Yes.
And there is not a single day when we don't come across with 1, 2, 3, 4, 5 pulmonary hypertension. Of course, not all of them are idiopathic. Some are due to COPD, which we call pulmonary. And
the other thing is
it also increase the incidence of
coronary artery, ischemic heart disease. It also increase
The next question to you, Dr. Kumar, is how frequent is the pneumonia during pregnancy? How common, how frequent is the pneumonia during pregnancy?
Pneumonia is one of the most common non-obstetric complications and the leading cause of death in pregnant women. It is the third most common cause of death in pregnant women. The reason behind the high incidence of pneumonia is that as soon as uterus grows upward, it pushes the diaphragm upward, which leads to decreased clearance of secretion from the lung. The other thing is hormonal changes, which leads to decrease in T cell activity and cellular immunity. That makes the patient more prone for the infection. These are the reasons why pneumonia is more common in pregnancy. The second thing is since many physicians or gynecologists are reluctant to X-ray during pregnancy, so it leads to delayed diagnosis in the pneumonia. The other thing is since dyspnea is a common problem during pregnancy, that people think it is maybe physiological. So this also leads to delayed diagnosis in pneumonia.
Right. So what you are trying to say, that pneumonia is far more common than often realized during pregnancy, and it could be cause of preterm labor as well. Thank you, doctor. Now, my next question is to Dr. Sunil Harsh again. How the cases of inflammatory bowel disease are managed in young female who want to conceive? How the cases of inflammatory bowel disease are managed in young female who want to be conceived?
Thank you, sir. Thanks for the question. Inflammatory bowel disease mainly is declassified into two diseases mainly, the Crohn's disease and ulcerative colitis. So what we commonly see in India is ulcerative colitis, so I will be discussing more with ulcerative colitis. Ulcerative colitis in infertility in a young couple. So once a female is going to conceive, then she should be waiting for a period when her disease, when her UC or Crohn's anything, is in remission. So what happens? As a thumb rule, if someone is having IBD and she conceives or she is pregnant, then 1/3 of them will never go into relapse. 1/3 will maintain the status quo at the time she conceives, and 1/3 will relapse. So the second one is when 1/3 will maintain the status quo. So once she conceives during the period when she is in remission, then that means that 1/3 and 1/3 goes along with it. So she is around 70 to 75%. She is having chances of not going into relapse during her pregnancy tenure. So first of all, we should be counseling the patient that whenever you are planning for conceivement, just plan when the disease is in remission. Another thing, during the counseling, we should be checking whether the patient is in any immunomodulators. Like many of these patients are prescribed azathioprine, like methotrexate, or mainly azathioprine is the drug which they are taking for maintenance. So azathioprine might be having many of the fetal side effects. So they should be told that azathioprine, or if they are taking all these types of cyclosporine or sometimes cyclosporine, so these drugs should not be there. So the counseling part is very important. Another point, sometimes the young female comes, she wants to conceive and she has a male partner who is having UC. And they are having infertility for quite a long time of time. And every time they go to a gynecologist or an infertility center, only the lady is being checked or counseled. And the lady says that she doesn't have any problem. So UC can affect a couple, even a male is having or is on drugs. Because any drugs like whatever we give, mesalamine, sulfasalazine, these type of drugs do cause decrease in sperm count. So less sperm count, less fertility. So that is one of the pitfalls which we generally miss, or which the gynecologists, sorry to say that, but gynecologists mainly are concerned with the female part. So I have seen few patients where they were having infertility, the husband was having ulcerative colitis and was on drugs. So now the lady is pregnant, and once she is going on, so 75% in remission, she is not going to have relapse. So even if maintenance dose of mesalamine or sulfasalazine, mesalamine is a choice of drug for maintenance if the patient is not having any extraintestinal manifestation. So mesalamine will be a better drug for maintenance during the pregnancy, and if she is taking mesalamine and she has conceived during the remission period, then there are high chances that she won't be having any relapse. Another thing is, because of UC is a chronic inflammatory process, every one of us know that. So these patients might be having loss of more of vitamins and minerals. So more of folic acid, we keep on giving during ANC also folic acid is given. So just we have to counsel that they stick to the drug regimen. They keep on taking the drugs regularly, and yes, I think that will help.
But you are trying to say that mesalamine and sulfasalazine, if the lady in the remission with these drugs, she should continue the same.
She should continue and
in the same doses.
Mainly, sir, the doses is for maintenance dose. It is 2.4 gram, and pregnancy itself says that if the disease is in remission and the pregnancy is there, so pregnancy itself will physiologically suppress the disease. So that is definitely a clinical judgment. There has been no RCT or Heidenheim trial which says that you can decrease, but maintenance dose is 2.4 gram. Yes, you can decrease and you can go with 1.2 gram as well, because pregnancy as a physiological suppressor might.
Suppose she is not in remission, and she won't mesalamine as well as on steroids.
Sir, the first thing which we discussed was, if the patient is not in remission, then she should conceive. Because
she is conceived, and this is a precious time.
Okay, so if she is conceived, then there is no teratogenic effect. It's a class B drug, mesalamine. So she can continue. Whether she is taking steroids as a maintenance or to induce remission.
To induce remission, and she is still under remission, but just started.
If steroid is used for induction of remission, and if remission is already induced now, then definitely the steroid cannot be continued for maintenance. Even for normal patients, steroid should be continued as a maintenance. So should be tapered and should be taken off.
What is steroid suppositories and all that?
Suppository, if you take systemic steroid, then definitely it is having a more side effect. If you take suppository, then it depends which type of UC the patient is suffering from. The patient is suffering from UC E1, E2 or E3. If the patient is suffering from E3, then suppository steroids wouldn't help. if the patient is suffering from E1, then yes, suppository steroid might help, but already the induction has been achieved, and suppository steroid even does not need to be tapered off, it could be stopped abruptly. And another thing, like budesonide is being used now, so budesonide has less side effects, so I don't think for induction also now the systemic steroids are indicated.
Thank you very much. Now it is the turn of side effects of non-steroidal anti-inflammatory drugs, which we use right and left.
Thank you, sir. Thank you for your kind word of appreciation. Although I know more than anybody else that I hardly deserve them. I also would like to thank Cadila for this wonderful opportunity. In fact, I would like to tell them that I had the distinguished opportunity to meet Sri Indravadan Modi himself way back in 2010. At that time, at the age of 84 years, the kind of energy he had, and the kind of vision, and the kind of conviction he had was definitely something to learn from. That was the time when he talked about Risorin, he talked about ATTs. He said that not much innovation, not much research has gone into ATT drugs, and his company is trying to correct that, and therefore he came up with the brand Risorin. Anyway, so it is a glad moment for me to be here. Thank you for the opportunity, Canada. Now coming to your question, sir, NSAIDs. Now I would like to broaden the question a little, because before we started I had the opportunity to mingle with the crowd, and I could see a lot of PGs are there from Katia Medical College, and they are young and they are very impressionable. So the message first and foremost I would like to give is that our treatment has to be holistic. We need to see why at all people end up taking NSAIDs for a long duration of time and therefore become a sufferer of the side effects. So treatment has to be holistic. The conditions like osteoarthritis, rheumatoid arthritis, and other common things like low back ache are not treated properly. Only drug part is probably written and patient is not counseled properly, and therefore they end up taking NSAIDs for a long duration of time. The side effects are multifarious. First up is the GI side effect. We all know that it can lead to gastric ulceration, gastric irritation, and all the kind of gastric problems. But the story doesn't end there. NSAID taken for a long duration of time can affect all the bodily functions, including the heart, the kidney, the liver, as well as the the ovulation, things like ovulation in ladies. So if you talk of effect on kidney, we know that it can lead to, if taken for a longer duration of time, if taken in higher dose, it can really lead to chronic renal failure, because nephrons are going to suffer. For hemodynamic things and for heart, it will have an effect on the drugs which are being taken by older people, like those for heart failure. It is going to interfere with the antiplatelet activity of the drugs being taken, and therefore it is going to affect the patient. And in the liver, it can have a deleterious effect. It can lead to really the architectural disintegration of the liver itself, and therefore lead to chronic liver failure. Thank you, sir.
So what you are trying to say, that rather than jumping on NSAIDs for a long time,
Yes, sir.
let us get on to find the cause of that pain.
Sir.
And if it is osteoarthritis,
Yes.
if it is rheumatoid arthritis,
Sir.
or if there is anything else which can, during which you will give non-steroidal anti-inflammatory.
Certainly, sir. That is my message, sir, to my audience.
This thing I would also like to say that non-steroidal anti-inflammatories are not only analgesics, there are many more who have got far less side effect than these. So that should also be included in your prescription.
Certainly, sir.
The next question to you is Dr. Anand.
Sir.
Tell us a bit about osteoporosis. In the modern scenario, how should we treat osteoporosis? I don't want to know anything about the diagnosis. Once the diagnosis of osteoporosis is made, how do you go about it?
Right, sir.
Calcium, vitamin D, phosphonates, etc., etc. How do you treat them as an orthopod?
So, once again, as I said earlier, in my treatment, in my principles, in my philosophy, the holistic approach is the best. We know that osteoporosis is a silent epidemic. As we are having more elderly in our society, more and more people in our neighborhood are falling prey to osteoporosis. Osteoporosis is the condition where there is reduced bone mass and micro-architectural disintegration of bone, leading to increased bone fragility and more susceptibility to fractures like hip fractures, like fracture of the wrist, like fracture of the vertebrae. So, not only drugs, but other things like exercise, modification of lifestyle, they should be considered and stressed upon. But coming to the treatment part, the drug part, of course, calcium, once we are above 40, especially in female, especially after menopause, the catabolism of calcium is more than anabolism, and therefore the bones lose calcium. So first up, we have to give calcium, sir. Calcium with vitamin D3 is the most common treatment modalities at the moment. But in certain cases, there are adjuvant drugs like calcitonin, like bisphosphonates, like PTH. They should be also be started. If a patient is really a severe case of osteoporosis, the latest treatment is parathormone, PTH. PTH, like if your bone has lost calcium, so you put calcium in the bone. You put calcium in the bone and then give medicines which will prevent that calcium from going away from the bone. It is like in your account. If your bank account is empty, you will put some money in your account, and then only you will devise ways that that money that you have already put in the account doesn't go away. So for a patient who is severely osteoporosed, such patient should not only be put on calcium but also on PTH. PTH given daily in particular prescribed dose will increase the travel of calcium into the bone, and then you can resort to giving bisphosphonates, which are of different kind, which can be given weekly or monthly or even yearly. So giving PTH will increase calcium in the bone, and then bisphosphonates will prevent calcium from going away from the bone. At the same time, you can give calcium, and you can also make the patient aware of the benefits of things like exercise and things like that. Thank you, sir.
बहुत ही मारवाड़ी नुमा जवाब दिए हो, कुछ खाता में डालो, कुछ खाता से निकालो. Now talk about calcium. How do you prescribe calcium to your patient, and what calcium?
Yes, sir. We have different kind of calciums, and we have calcium carbonate. We have calcium carbonate, we have calcium orotate, we have calcium citrate, we have calcium citrate malate. We also have oral calcium, and every calcium claims to be better than the rest. So I am really not very sure about it. Let me be very honest. And this question I have put in different fora to different people. They say that something that may work for one person may not work for the other. So yeah, the jury is still open. I will give any of the things, maybe calcium carbonate.
So you don't have any choice for calcium, all are good or all are bad.
Certainly.
What about vitamin D? We do have a lot of information nowadays, giving daily, weekly, monthly, injectable, oral, in the form of nano. Which one is the best? I don't know. And if you give something 125 molecule daily, and then still I see a prescription where it is written vitamin D 60K once a week. Is there any rationale for that?
So, vitamin given initially 60K is given weekly, and some people even prescribe giving 10K daily. I had a talk with no other than Dr. Mawa, who is based at Delhi, and he is the only person from India who is invited in one of the best conferences on osteoporosis worldwide. And his view, after much of research and everything, is that even 60K is not sufficient. It has to be 120K weekly actually. So that is the fact. But yes.
What about giving every day alpha-calcidiol, for example?
Sir.
Versus vitamin D, 60K or 120K, whatever it is. Is there any difference between these two?
So different theories and different research work, again, one study would favor this method of giving, the other study would favor that method of giving. But I'm not very sure which one to call the better one.
Now, I take this opportunity to ask you, this vitamin D deficiency, there is a lot of halla-gulla about it. Is that really true that we have that many cases of vitamin D deficiency in India?
Sir, even if you now conduct a test among the people present in the hall, maybe 80% will be insufficient and 50% will be deficient. So it is really a hoopla and hype created by pharma. For me, that is the thing. Yes, sir.
I feel that the cutoff point
Yes.
of normal and deficiency is
too high.
Yeah.
Yes.
It should be less than that.
Certainly.
Because nowadays we do have cases, they do umpteen number of cases and it includes vitamin D. And every second report is vitamin D. We do not have the fourth panelist today, so I will ask the learned audience, if you do have any question to these scholars, please come forward and ask any question you wish to, according to their department. We have got gastroenterologist and cardiologist. If you do have any question, please raise your hand and ask.
Hello, I am Dr. U.P. Singh, and my question is, and what is the difference between the diabetic gastroparesis and non-diabetic gastroparesis, the etiopathogenesis, please?
The etiopathogenesis we discussed was mainly there are two things in diabetes which can be causing it. Number one is the delayed gastric emptying. Delayed gastric emptying could be from the gastric emptying, could be from the less fungal contraction, could be from the lesser the food which we normally take in or the patient is taking in. Like for an example, if someone is taking vegetables and salads, so the time it will be stayed over there in the patient's stomach will be 20 minutes. And if someone is taking beef, it will stay over there for 180 minutes. And then definitely what of the other ingredients. Similarly, once it passes down the intestine, then what is the muscular contraction? You must be knowing that there is major motor complex. So major motor complex is just like intestine also acts just like heart. So there is a stimulation which goes from the stomach to the colon, and it fires after every 1.5 hours. So 90 minutes. It fires every 90 minutes. And because of all this, like diabetes is just not a sugar control, it has multifarious effects even on the nerve. We know like there are neuropathies, and so once these neuropathies are there, so once it is acting, these electrical complexes which is going on over there, so they goes on, the amplitude of these electrical complexes will be slow. Another thing which we were talking about was the cells of Khazal, which are present in the submucosa. They keeps on working as the amplifier, like what we have like just as a transformer. So these cells keeps on firing, which help the smooth muscles to contract. And these are not the longitudinal smooth muscles, these are the circular smooth muscles. So once the circular smooth muscle contracts, so it causes help in emptying. So once these nerve cells are damaged due to any part, then any of the regions, then that might be causing delay in the gastric emptying. So both the sympathetic and parasympathetic nervous system could be affected by the multifarious side effect and the poor hypoglycemic control of the diabetes, which might be leading to the gastroparesis, which might have different sort of disease. And as I said before, that gastroparesis, you have to classify what sort of gastroparesis. Whether it is delayed gastric emptying, whether it is dysmotility, whether like what sort of gastroparesis is. Like in diabetes type 1 and type 2. So diabetes type 1 will be having 5% of these patients have mainly complaints of gastroparesis. Whereas if the patients are of diabetes type 2, then around 17 to 20% of these patients have complaints of gastroparesis. So this is very important to understand. Diabetes type 1 patients, normally they are not so obese, they are not so elderly, they are not so lethargic, but still having 5% of them. And similarly, if once it goes to diabetes type 2, the percentage is 4-fold high. So does that mean only the glycemic control or only the sugar control and the drugs are causing it? It's not there. As Dr. Krish Mohan was telling you about the obesity. So obesity, lethargic life, and all those type of things might also contribute, which you can see from the data, 5% to 20%. Diabetes type 1 and type 2. Another thing is, yes, you have to see which bloating, all those type of stuff, and you see you are having a good meal and all those things, you see there is functional dysmotility, then you can use other drugs like agosamide. If you think it's SIBO, it's something different. So it's completely different.
Thank you very much. Just a minute. Dr. Harsh, you have nicely described everything. But I want to know, particularly in diabetic gastroparesis, the good control of
he is suffering from gastroparesis. Patient knows that he is suffering from diabetes, he is suffering from impaired sugar. So patient is not coming to a gastroenterologist for the first instance. Patient is going to a physician or to an endocrinologist seeking good glycemic control, good sugar control. So already the first part is being discussed with the endocrinologist and the MD physician. So once they are not able to work, once they just don't want to treat that in particular, then they send it to us. One patient, I will discuss it over here. The patient is from Khoski Bagh. He is a good, wealthy Gujarati businessman, meeting very qualified treating doctors from Purnia, having all, and on records he was having just high HbA1c, else everything was controlled. He was having major complication was something like it was diagnosed as irritable bowel syndrome. Saying it as irritable bowel syndrome, constipation, giving different drugs for laxatives. The only good drug, one good drug which improved his bowel, and the patient HbA1c was controlled. So sometimes it even happens that you are giving a lot of drugs and you are not counseling the patient well, you are not telling him about what all things he has to avoid. So it is just like Dr. K.S. Anand repeatedly said, the holistic approach, and which you are also pointing out, that why not to discuss. So definitely our teamwork is very important. So teamwork, once it is a teamwork, we can definitely we can surpass all those high modalities of testing, and we can discuss it with the patient and we can give him a better option. So yes, and all those things like gastroparesis, treating gastroparesis, diagnosing gastroparesis, documenting gastroparesis is all, like you need all those manometry, duodenal manometry, if you really want to do all those things. And in the overall things, we can just have a good discussion with the patient, the treating physician, and we can just make a conclusion that which all drugs, and every patient is a different patient. You cannot say that you give domperidone to this patient, so the next patient which is coming to you will be benefited by domperidone. So it depends. Every patient has different setup, different response to different patient. So we have to discuss it.
Any further questions or comments, please? Please note there is a prize for asking good questions. Isn't it? Ketla Babulo? One who will ask very good question will get a prize.
Yes, sir. Yeah, sure, sir.
Any comments? I think so last question I will take, which was made for Dr. Juha. Since we have got a DM Gastro here, what is your opinion about GERD and pregnancy?
GERD and pregnancy, GERD which we already know, and why GERD happens. GERD happens because of when there is a lower esophageal sphincter is quite relaxed, or someone is having more abdominal pressure. So pregnancy is a very good physiological thing where the abdominal pressure will increase. So many of these patients will be coming up with GERD. So I would even like to say that there are few studies where young patients were questioned about GERD, young female patients and the patients who were pregnant. So I would like to declassify over here is they were not statistically different. So though the question says that the patient is having a lot of will increase the symptoms of GERD, there was a head-on-head study which said normal non-pregnant patients also complain, so 15% they say they have GERD, and some are less than 20 or something, even pregnant patient. So even if we consider that, so physiologically many times the patient might not be suffering with GERD. Even if we consider that the patient is suffering with GERD, then many of the PPIs which we normally use are quite good and they are class B drugs. Only one drug which is not class B is omeprazole. Other than omeprazole, all drugs like pantoprazole, Revelop of Cadila Pharma, everyone is class B. So we can counsel the patient, we can use PPI. These are the class B drugs. And definitely how much studies are being done, there are few side effects of all the drugs. As already discussed before, Dr. Krishnan told that pregnancy patients have more of pneumonia as reported. So yes, and the various papers they say that continuous use of PPI also causes microaspiration and they might cause some sort of a pneumonia. So though I cannot quote many papers on it, but yes, I will say if after counseling, if not indicated or if the patient can go better, then less use of PPI, and many of the PPIs are class B drugs. Only omeprazole class C.
Are you trying to say omeprazole should not be used in GERD in pregnancy?
Yes, a class B is a better choice to make rather than class C.
In fact, there was a study by Americans that omeprazole, which is a class C drug, should not be used for pregnancy and birth. But subsequent studies failed to say anything about it, and now it is presumed that all PPIs are safe in pregnancy and can be used in GERD or any other condition which is indicated. So the last chance of any question or comments from our Honorable Chief Guest, Dr. S.P. Singh Sahab.
I would like to ask to Dr. K.S. Anand, what will be the amount of calcium to be called as osteopenia or osteoporosis?
Sir, actually there are methods to classify that, and DEXA investigation is one. If it is 2 standard deviation below normal one, that will be osteopenia, and beyond that it is osteoporosis. Yes. So what is the right amount of calcium? It differs from age to age, from race to race, and from in different sexes. So the amount of calcium that I have will definitely be less than somebody who is maybe 30.
What will be the total amount of calcium in the body? What is the total amount?
No, sir. The way I understand is, it is not a correct question in itself, because I still may be having less calcium than somebody who is 30 years. Still, I will not be osteopenic, osteoporotic, because I am having the correct amount of calcium for my age and for my race and for my sex.
The age of the patient and the length of the patient.
Yes. So osteopenia, osteoporosis is something relative. For a 70-year-old person, if he is having an average calcium for that age, which is right for him, he is still having the right amount of calcium. He is not osteopenic or osteoporosis. So the amount of calcium, the actual amount may differ from age, race and sex. Thank you, sir.
On examination of X-ray, they comment that osteopenic bone marrow. How
Sir,
comment?
those days are gone in today's day of digital X-ray. You can really increase the brightness and the cortex will appear thinner. So in conventional X-ray, because our mind and eye were trained to seeing a conventional X-ray in which the amount of exposure was always uniform, so still we could comment. So even today, even certain centers, they do not like digital X-ray. They still like conventional X-ray, because in that, the thickness of cortex, in osteoporotic bone, the cortex will appear thinner and the bone will appear more hazier, more blacker, not whiter. So in today's day of digital X-ray, that thing is gone.
Now the last question to Dr. K.S. Anand.
Sir.
He often visits nationally and internationally and attends and gives lecture in many orthopedic CMEs and conferences. What is there on the horizon and what is the new in orthopedic surgery or treatment? Please tell us.
This is very different from what it used to be. Now there are 21 sub-branches in orthopedics. So there is something new in trauma management, something new in joint replacement surgery. There are many things new in spine surgery. But there are certain things that I would like to bring to the fore. The first and foremost in trauma management nowadays is 3D imaging, 3D models. For complex fractures like fractures of knee joint, fractures of pelvis and fracture of calcaneum, we initially only used to have X-rays, and then after that we started having CT scan. But now, with the advent of 3D printers, we can actually have that fractured pelvis model in front of us. And when we have that model in front of us, then we can see it from all around and practice our fixation. We can actually measure the size of a screw. We can see from where we want to put the screws. So 3D imaging, 3D model is something new in trauma management.
Is it done by X-ray?
No sir, we do a CT scan, then we by software, we prepare a 3D printable file, and that 3D printable file is fed into 3D printer, and in no time we'll have a model in front of our hand which will be the exact replica of the bone which is there inside a human person. That is one thing. Apart from that, there are a lot of hue and cry is about the, what do you call it? Just forgetting that studies into the pluripotential cells or stem cell therapy. Yeah, stem cell therapy. Stem cell therapy does have a role in many of the diseases in orthopedics as well. But बहुत सारे लोग they are really bending this term and making people, they are making a fast buck out of it. So you have to be very careful as far as stem cell therapy is concerned. But it has role in conditions like osteoarthritis, rheumatoid arthritis, in conditions like avascular necrosis of hip joint, and even in spine injuries. That is one, sir. Thank you.
Thank you very much. Now I hand over this mic to the Kerala people to take it further.